So our final speaker of the day is Professor John Crown, who is just waiting here ready to begin. John Crown is a consultant medical oncologist at St. Vincent's University Hospital in Dublin. He is an oncology thought leader who has published extensively in clinical and translational breast cancer research and has been the co-author of 280 research papers. John founded the Oncology Clinical Trials Unit at St. Vincent's University Hospital, which has developed an international leadership role in oncology clinical trials. He has served as an independent member of Shannon Éireann from 2011 to 2016. He is involved in health policy and health reform advocacy. John has strong Leitrim roots, his father being from North Leitrim. His presentation title this afternoon is Ending the Veil of Tears, Reforming Ireland's Broken Hospital System. John Crown.
Good, Regina. Tommy on bhuiach don Skull Sour Sean McDear for Incura, Laura live in you. Tá Bron Urim, knock will me, Igunde Leitrim, Igilchi Clahar, Laura live Gaparsanta. Ladies and gentlemen, thank you very much for the opportunity to speak in the summer school. It's a great honour to take part in this event, honouring a great Irishman and a great Leitrim man. As Regina has just told you, I'm mostly a Leitrim man myself. My own father, Lord Rustum, and all of his family came from Lurgan, about a mile and a half from Hamilton, a beautiful part of the world. And his father and grandfather before him were also from there. So my roots are very deeply dug into that land under the shadow of Benbow. Ladies and gentlemen, it will not come as any surprise to you to hear that there is a high level of dissatisfaction with the Irish hospital system. And I must say at the outset, this is not ignoring the fact that so many people have had wonderful, compassionate, professional, and expert experiences interacting with the Irish health and hospital system. At a time in their lives when they were at their lowest with illness and despair, the hospital system is often there for them. It is also a system which is staffed by, I believe, as good, as excellent a cohort of professionals, of nurses, doctors, physiotherapists, radiographers, hospital support staff, cleaners, as you will find anywhere in the world. But unfortunately, collectively, despite this great concentration of expertise, of compassion, of diligence, responsibility, the service which is provided, I'm afraid, is substandard. It does not measure up to what it should by the standards of most international Western European health systems. And rather than wringing our hands and oligoning about it, I think it's important for us to try and think of ways to try and fix it and make it better. We see the evidence for the problems in our emergency departments. Our emergency departments are so crowded at times that I sometimes wonder how they would pass a fire inspection, never mind a medical inspection. We see it with our extraordinary waiting lists, which we'll talk about in a few moments, our shortages of beds, our very small staff numbers. We have the smallest number in nearly every medical specialty for which records are kept. We have one of the lowest, or if not usually the lowest number of specialists per head of population. We're short of CT scanners, MRI scanners, operating rooms. We recently saw with the COVID crisis a very dramatic demonstration of the fact that we were desperately short of intensive care unit beds and of the ventilators, those machines which are necessary for patients whose breathing may fail for a variety of reasons, including coronavirus. Thankfully, due to the extraordinary efforts of the Irish people in sticking with the public health guidelines, we did not get the awful surge we feared we might get. And our intensive care units came close to being full, but they never were quite swamped. But this must not obscure the fact that coming into the crisis, we had the smallest number of intensive care beds per head of population of any one of the developed countries. These problems tend to get amplified at election time. And of course, I hate to be cliched about it, or to talk about cliches, but we usually find that opposition parties will rant and rave and rail about the deficiencies of the health system and the extraordinary irresponsibility of whatever government is incumbent at the time in failing to deal with them, and quickly flip into defense mode when they become the governments themselves, telling us how we must respect prioritization, resource shortages, and the need to apportion multiple demands on the public service euros. There are three, I believe, key core problems with the health service, and most of the problems I think will fall into one of those three categories. They are that it is unequal, very unfair health system, that it is very inefficient, and it is of generally mediocre quality. Well, the inequality is obvious. In Ireland, approximately one half of the population take out supplementary insurance. We call it private insurance, although in fact, in most cases, it's not all that very private. They take out supplementary insurance to give them options beyond those which are provided by the HSE-run hospital system. The access to care that people that do and do not have that type of insurance is very stark in Ireland. Ultimately, everybody will get the same treatments. Sadly, I have to point out there were a few cancer drugs which are now available to private patients, which are not available to public patients. I had never seen a problem like that before in Ireland, but that has arisen recently. But in terms of the speed of access to specialists, to surgery, to radiology procedures, etc., there is a gross disparity between people who do and do not have insurance. The second problem is quality. And again, I have to stress the quality is not because there aren't good people in the system, there are. But the product they deliver often leaves much to be desired. The main core problem with quality is waiting lists. I could start quoting you numbers on this, but it probably would be more illustrative if I give you some examples that I've been aware of. I saw a patient recently that was waiting 3 years to see a pain specialist. Think about that. Imagine you have a pain. It's a pain that's so bad that you see a doctor about it. It's so bad that your doctor cannot deal with it herself, and she refers you on to see a specialist in pain. And you're then told that you have to suffer that pain for 3 years until there's a gap for you to actually see it. The next problem I'd like to point out is spinal surgery for children that have abnormalities in their spine. Children can be born with curvature of the spine. They can develop curvature of the spine during childhood. Sometimes they need surgery for it. It's an absolute fact. The longer you delay the surgery and those who need the surgery, the worse the problem will be. As a result, in Ireland, because the waiting time is so long, children have a higher degree of curvature of their spine than they have in other European countries. This means the operation is harder, takes longer, is less likely to be successful, and is more likely to result in the child requiring intensive care unit support. Obesity surgery. It's all very well to get judgmental about obesity, but obesity is a real problem and some people just cannot deal with it. It's not as simple as people with willpower can deal with it and people who don't have willpower cannot. It's more complex metabolic medical problem than that. And it has been really well shown that for people who have the extreme degrees of obesity, the kind of obesity which gives you diabetes, which gives you heart disease, which gives you blood pressure, that surgery to the stomach to limit the appetite, to constrict the capacity of the stomach, has a powerful effect in improving the health of those patients. And what's more, not only does it have a powerful effect in improving their health, it saves money. On average, the money which is spent looking after the complications of extreme obesity would be recouped within 1 year or 2 years of having that surgery. When I was in Shanadair and I highlighted this problem, at the time, it's a little better now, but at the time there was a 7-year waiting list from the time a GP decided somebody might need an operation for obesity and the time they had the operation. Why was that? They had to wait to see the obesity specialist. They then had to wait to see the various other specialists and therapists who would give an opinion about the suitability of surgery. They then had to wait to see the surgeon. And then when they had seen the surgeon, they had to wait to get a slot on the waiting list. 7 years. Now, some people in the first year after having that operation get cured of diabetes. It can be an extraordinarily good operation, so it makes no sense whatsoever. The routine waiting time for scans, for x-rays, except in situations where there's a real risk it might be cancer or something urgent, those waiting times can be up to a year. To see some specialists, the waiting times are more than a year. Waiting times for things like hip replacement, cataract surgery, these things can all take extraordinarily long periods of time. And of course, what does that mean? For an older lady or an older gentleman who has a cataract and who can't read, that may be the 6 months or 9 months they're waiting for the surgery, maybe a miserable 6 months or 9 months when they actually are not able to do things that they want to do while they're waiting for the operation to take place. Ladies and gentlemen, there's a phrase that's used in the civil rights movement called justice delayed is justice denied. I would put it to you that treatment delayed is also treatment denied. I think there is a real need for us to recognize that this is a core problem with our health system and one which causes awful difficulty for patients. Another problem is inefficiency. The system is not a very efficient system. I always say we don't actually underfund our health system. In general, I don't tell the government you need to spend more on health, although in some areas they do. the funding is applied in a fashion which does not incentivize optimum use of the resources. Let me give you an example. I had a patient who was sitting in a hospital bed not that long ago for between 1 and 2 weeks waiting for a scan. Now, we were worried that she might have had something which would have made it dangerous for her to leave the hospital, but we couldn't be sure until we had the scan. The scan didn't get done for approximately, I think it was 9 days. And the end scan was fine. But during those 9 days, that bed was not available to multiple patients who could have come into the hospital and out for one-day treatments, one-day procedures, short admissions. And one has to ask, well, why is that? Why doesn't the hospital just make sure it has enough CAT scanners so that you don't have things like that? And the answer is fairly obvious. It makes sense if you're trying to stay under a budget. Using the beds inefficiently, keeping somebody sitting in a bed not doing anything for 1 week is a much cheaper way of using the bed than having it used by rapidly admitted and discharged patients. So again, I make the point, it's not as much underfunding, it's malfunding. We're hearing about a new proposal called Schlontecare. I'm going to come to that in a few moments, but I believe Schlontecare addresses none of these problems. If we want to fix our health system, we need to learn. And we need to learn by looking at health systems in other countries and look at how they do things. Now, I'm a bit nerdish about this. I'm a bit of a student of health systems. But for the purposes of today's discussion, we'll just discuss 3 international health systems, which I think each are good examples of one of the major ways of funding health. The United States health system is one that I believe we should not follow. It's one we can learn from, and there are certain aspects of it which are very good, but the core funding model of the American health system is not a very good one. The main problem is the United States does not guarantee access to healthcare uniformly to all of its citizens based on need. It does if you're over 65. And people tend to forget this when we think of the relentlessly private, capitalistic, profit and greed-driven American health system, which certainly is a valid criticism of many parts of the health system. America also runs the world's largest socialized medical system, which is Medicare, the federally funded program which covers most of the medical costs of all American citizens over the age of 65. Under the age of 65, there are also programs which cover those who are very poor, but in general, you have to be at bankruptcy level and apply for that kind of funding. The rest of the United States depends on insurance. Many Americans make the decision not to take insurance. Many Americans have no choice. They do not have the money to take insurance, which can be expensive in the United States. The result is that despite having extraordinarily high standards in medicine, some of the best hospital specialists, biggest number of Nobel Prizes, best outcomes for cancer of any country in the world, in general, by some of the big picture health indices, such as average age at death, life expectancy, infant mortality, and the very sad one, maternal mortality, the number of women who die as a result of a pregnancy or delivery complication. America does not do well in these areas. They're not the worst, but they're very mediocre in those results. And at the same time, they spend the most on healthcare. So it clearly is a system which has great problems. We hear much about the UK national health system, which of course exists a few miles across the border in Northern Ireland as it does in Britain. The UK health system, we'll have a little more analysis of in a few moments. It is a system that is a wonderful system for containing costs. Basically, every penny that's spent has to be approved by the government. And it does give good, broad access to healthcare. The quality of the care which is given, I believe, is not of the highest standard by European standards. The waiting lists are pretty much the second worst in Europe after ours. I often think the British must wake up every day and thank the good Lord that Ireland exists, because we keep them off the bottom of the league table for several important indices in healthcare, such as waiting lists and a number of specialists. They also have relatively poor outcomes. For things like cancer, the British do surprisingly badly. For a country which is extraordinarily sophisticated medicine and science, it does not deliver that high a product. So again, it's a system we can learn and emulate some parts of it. And certainly the people who run our health system at government level, I think, would like to just import it lock, stock and barrel here, which is often a rather lazy Irish attitude to things. Let's just follow the British and do what they're doing. I think we need to be a bit more critical. Before we go into an analysis of the different ways of funding healthcare, I want to just say right up front, I am a firm believer in socialized healthcare, in socialized medicine. I believe healthcare should be delivered on the ability, on need, not on ability to pay. This is an important distinction, but it's important to realize that there are different ways of achieving that end. One sometimes in Ireland would think that the only way that that can be delivered is if the government actually owns, runs, micromanages, and regulates the health system and is the sole employer of everybody who works in the health system. This is something which we do tend to hear, and I must say I'm not convinced of that. I think there are better ways of delivering socialized healthcare. Don't assume that the only way to do it is for the government to do it. The government should regulate it. The government should insist that it's delivered in a fair fashion, but I don't think it's good at micromanaging it. There are, in general, two ways of delivering socialized healthcare. One way, the British way, is called the Beveridge model. The Beveridge model was a model named after William Beveridge, who was a British academic, Liberal Party politician in the 1930s and 1940s, and was the intellectual father of the national health system. And basically, Beveridge models are models in which everything is derived from tax. The government takes tax money from people, puts it in a central fund, it runs and owns everything, it manages everything, and it doles out the money to the different hospitals according to government policy. It does not match what the government gives to efficiency or to activity. A place which is working well can get the same amount of money as a place which is working badly. There is another way, a better way of delivering equitable, socially responsive, socialized healthcare, and that is the model which famously is used in Germany, and it is what's called the Bismarckian model. We all tend to think of Bismarck as this ferocious German near warlord and bureaucrat from the end of the 19th century. We think of a mental picture of him wearing one of those funny old German helmets with the spike on it. But in addition to his role in unifying Germany and expanding Germany in many ways, he actually introduced what was the most durable social and health insurance system in the world. In the 1880s, recognizing, as he saw it, a threat, this rising threat of Marxism that was starting to rear its head in Europe, he decided to preempt it by introducing a number of far-reaching social reforms, and one of them was health policy. And he introduced a model of mandatory health insurance, which in Germany has lasted through 2 world wars, the Great Recession, the Depression, the division of Germany, and the unification of Germany. And this is the health system which we saw perform so spectacularly well in the recent COVID crisis. It performed so much better than the British and so many other places in Europe did. And how does it work? You must have insurance. Mostly the insurance is not, and this is critical, is not paid to a private insurance company. It's paid to a not-for-profit sickness fund. And if you make more money, you pay more money. People who are rich pay more to get the very same insurance that people who are not so rich pay less money to get. I'd pay a lot more money to get this insurance than somebody who had a lower wage, but in the end, we both have the very same insurance docket. We can both take it to any hospital or doctor we choose, and the doctor in the hospital cannot say no to us. This is a really good system because it kills waiting lists at a flash. Nobody wants patients on a waiting list in a system where you get paid to do things. Of course, the risk in that is that doctors and hospitals can abuse the system and do things which are unnecessary in order to line their pockets. But honestly, this model is used all around the world, and there are ways of policing it, ways of putting guidelines in place that tell doctors and hospitals what they can and cannot do and prevent them from gouging. But really, it is a system. It would be a little more expensive, but it, in a flash, would kill the inequality, it would kill the poor quality, and it would dramatically increase the efficiency. So what attempts have been made to reform the health system in Ireland? Well, many. But in modern times, the first one was about 15 years ago at the introduction of the HSE. And the HSE at the time looked like it was just basically going to be an administrative maneuver to rationalize the way the old geographically based health boards worked. And one of the main arguments which was raised against the health boards was that they were very swayed by local political influence. Somebody who wasn't getting their operation or their bed in the hospital would call their local councillor, and he would call the health board, or she would call the health board, and they'd get the problem fixed. The HSE was supposed to bring in a more rational and central structure to it. Well, it did that, but in fact, it became more than that because the HSE became not the administrative management, but the HSE, as we have recently seen in COVID, is now being used basically as the brand for the entire health service. I'm personally a little bit troubled by the idea that the service is an executive. I think it would have been better to call it a health service. Minister Mary Harney, who had a great reputation in so many ways, made some brave attempts to change aspects of the health system. She certainly caused some improvements in the cancer services, left it far from perfect, but she left it better than she found it. But the problem, I'm afraid, is that her attempts to reform the larger health system did not work. She had the idea of trying to preserve the public and private mix by having co-located private hospitals built on the campuses of public hospitals, and also by having different consultants of different kinds of contracts. She basically planned that there would be some consultants who would be offered what was called a Type A contract, which was a very, very large salary, between $250,000 and $300,000. And in return for that, they could do no private practice. Others were offered more traditional contracts with smaller public salaries, but with the flexibility to also work in the new co-located private hospitals. Well, the whole thing really came a cropper with the recession following the bank crash in 2008. Many doctors did take those Type A contracts, but I can tell you it had no effect on waiting lists. It had no effect on quality. It had no effect on efficiency, because that was never the problem. The problem was never that some doctors were doing private practice. The problem was that the hospitals themselves were not incentivized to keep people off waiting lists. Fine Gael in 2011 came up with the idea that they would bring in mandatory insurance, and indeed their prospective coalition partners, Labour, had a similar model in 2011. They were elected. It was a central plank of the new government that they were going to bring in single-tier occupationally based insurance. Sadly, it didn't happen. Then Minister James Riley in 2011 stated that, well, it is a good idea and we will do it, but we won't do it until after the next election, when we're in the second term of government. I must say, this left me very cold, and it reminded me of the old story about the groom who was on the altar with his beautiful young bride, looking into her eyes, but to pledge fidelity to her, and said, I pledge faithfulness, but only after the first year of marriage. My own sense was, if they were going to bring in this reform, why didn't they just go ahead and do it there and then? Sadly, in 2012, the new Minister for Health, our now Taoiseach, Leo Varadkar, announced that his Department of Health officials had studied the proposal and deemed it not to be feasible. And as a result, they would not proceed with it. Well, ladies and gentlemen, I would put it to you that, this proposal would have taken a whole lot of power away from the Department of Health. And again, I was reminded of the old idea that perhaps if one commissioned a group of turkeys to discuss the feasibility of Christmas, they might also deem it not to be a feasible festivity. So no reform, but after the 2016 election, we were told we were going to have an Oireachtas Committee on Health Reform, jointly chaired by Deputy Roisin Shortall, who had a long interest in health reform, and it produced a report known as the Sláintecare Report. And the Sláintecare Report is long on aphorisms, short on specifics, and there's no part of the Sláintecare Report that I can see whatsoever that does anything about waiting lists, that does anything about staff shortages, that does anything about inefficiency. All Sláintecare does is state that it will deliver single-tier healthcare by removing that small number of private patients who currently use the public hospitals from the public hospitals. It does not ban the private hospitals. It just tells the private patients in public hospitals, if you wish to stay here, that's fine, but keep your money. Your insurance companies can keep their money in their bank account, and you can just use the system the way everybody else does. Ladies and gentlemen, that is not really a reform. That is not addressing any of the core problems. And again, looking at the Sláintecare Report, it sometimes looks like it reminds me of a Miss World acceptance speech that was written by management consultants. So let's go back and decide, is there anything we can do? Is there a feasible option? And I've always been troubled by this idea that in 2012, the government had a long established, very definite, across two elections, in fact, ambition that when they were in power, they were going to reform the health system with mandatory social insurance, and then so they couldn't do it. But how unfeasible can it be? Because let's think for a second, maybe we have it already. 1/3 of the Irish population are insured with VHI, the voluntary health insurance. Now, we all think of VHI as private insurance. It in fact isn't that private at all. It's owned by the government. Its only shareholder is the Minister for Health. It cannot act according to commercial insurance principles. It cannot reject the application of people who wish to join the organization as customers. And it's community rated. When you look at all of those things, that to me is not exactly private health insurance. It's certainly not run like a private business. It is social health insurance. And in fact, if we think of the great socialized health systems like Germany or like Canada, what they cover their hospital costs is exactly the same as what VHI is now. So in fact, there's nothing very radical about the proposal of trying to introduce uniform German-style social insurance in Ireland, because 1/3 of the population already uses it, and another approximately 20% take similar insurance from private insurance companies, who actually, again, are forced by appropriate law to follow some of those still socialized principles, such as community rating. So, ladies and gentlemen, I would put it to you that we can fix our health system. It will require a little bit of, if you'll pardon the cliche, thinking outside the box. It will require us suspending this old idea that some people are public patients and some people are private patients. Everybody could be the same kind of patient. Now, there are two ways of doing that. Way number one is to just ban all private medicine, which I think, well, as somebody would say, he would say that, wouldn't he? I wouldn't favor that, because I don't think that looking at the system which works relatively well and the system which doesn't work that well at all, and saying, well, let's just get rid of the one that's working relatively well and that'll fix all the problems, it obviously won't. To me, it makes more sense to try and give everyone access on a fair and equal basis, with people like me and other high earners paying more to make it happen, to enable the rest of our citizens to enjoy the same standards of healthcare that the approximately 50% of patients who take out individual insurance do now. Again, thank you very much for this extraordinary honor to be allowed to address this great summer school in the land of my father. And I do hope you invite me back again so that I can actually go up in person,